Yeah, so our study is really looking at what happens to patients' weight after they stop taking the new weight loss drugs. So, we've all heard about, Wegovy or Ozempic and Mounjaro. They've sort of really changed the landscape of pharmacotherapy for weight management. Studies have shown that they lead to sort of weight losses of about 15 to 20%. But what we were interested in is when people stop using them, and they do, about 75% stop using them within 2 years. And we wanted to see what happens to the weight and a few other variables that we talk about in the study. Um, and that's sort of the crux of the whole study. So I think to answer that question, it's important to consider how the drugs act in the first place. So these drugs are GLP-1 receptor agonists. They really make use of the body's own system for regulating appetite. But what we're doing is they're really acting more so as a brake on the appetite. And whilst you're on the drug, you obviously are eating less because you feel less hungry. And when you are eating, you're eating smaller portions. So that it leads to an obvious calorie deficit, which then goes on to translate as weight loss. When you stop taking the drugs, the idea of an exponential recovery curve first actually occurred to us if you look at the raw data from some of these trials. So, as an example, is Step 1 extension trial, Step 4, and Surmount 4. And these trials look at what happens when you go off of semaglutide, which is Ozempic, and tirzepatide, which is Mounjaro. And if you look at the curves that these studies do, and these are the raw curves without any modeling, you can see very clearly that there's a very initial rapid rebound in weight, which then sort of starts to plateau and reach a new steady state. And that's really, in keeping with first order principles of weight changes. Weight is really quite a dynamic variable. So that is why we sort of opted really to kind of model it as an exponential recovery curve. And, the model fit, we've done quite a few sensitivity analyses that are in the appendix of the paper. And the model fit, seems to hold, which is sort of encouraging to see. What's driving it is the fact that, once you take your foot off that brake, you really do tend to regain weight quite rapidly. And this really goes to the point that these drugs aren't a magic fix. They're not a bullet kind of for weight loss that's going to make, so to speak, the way that you do lose is not going to be permanent without having some lifestyle changes, changes to your diet, changes to your exercise and sort of your eating habits. Those are important to be worked at in order to sustain that weight loss across time. And for the plateau, the model does actually, although, there is 75% weight regain, there is still a 25% residual weight loss that seems to remain. And it's kind of interesting to see that, and there's might be a few factors at play. These participants who were on the trials typically sometimes tended to have quite strict regimens in terms of diet and exercise. Now, some studies kept them on that regimen after they stopped using the drug, others didn't. So it's a little bit difficult to discern how much of a factor that's playing. Or it could also be, for instance, individuals developing their own healthy eating habits. So whilst they're on the drug, perhaps could that influence that? And also, to what extent could there be sort of a resetting in terms of your the hormones that drive appetite in the brain? So there's a few factors at play, and it's difficult to discern how much each factor is contributing to that. But there is a bit of residual weight loss, which is quite clinically significant. Yes. So I think the study really serves. The main point of the study is to say that there is a risk of weight regain, and that both physicians and patients should really be made aware of them. Um, because other than being on these drugs indefinitely, which doesn't really seem sustainable at first glance, we need to really kind of look more into how we prescribe these drugs. Uh, one example that we gave is from a study which kind of the difference that they did is instead of having the patients go from being on the drug to being not on the drug the next day, is instead to kind of dose taper. So they gradually reduce the dose and to the minimum amount that you need to kind of maintain that weight loss. Now, some people could come off the drug and maintain the weight loss. Some had to be on the drug. That is only one study, but it did find that dose tapering could potentially help sustain some of that weight loss. But whether that holds true, in wider picture, because clinical trials are a perfect picture, whereas real life patients are a bit more complicated. Um, it's not sure, and I think there's probably more data that needs to be. We need more data to kind of verify if that holds true. Um, so I think they also paint a similar picture. So it's important to keep in mind that actually GLP-1 receptor agonists were originally developed for glycemic control for diabetes. Liraglutide kind of came on and showed a bit of weight loss, but that's how they were originally designed for. When you look at these other cardiometabolic variables, you see similar, improvements whilst they're on the drug, but then rebounds with because of so the very few studies actually look at cessation outcomes. So unfortunately, there is a bit of um, restriction in terms of the data that we had and how reliable that data is. But what we were seeing across most studies was that there was a rebound in those sort of cardiometabolic variables as well. So just like with weight regain, HbA1c and systolic blood pressure, which is what we tracked, seemed to show a rebound, which could why that is could be a bit of a chicken and egg, whether it's because of the weight regain or because of other organic causes, but they show similar patterns. So that question is actually very difficult to answer, and that's a question that we ourselves had, which is to say that, well, can we look at certain variables in our sensitivity analyses to see, well, what could be driving weight regain? Are there factors that could perhaps influence that? The problem that we've got, and actually the problem that the whole field has got, is that cessation outcomes again are very limited. Although we had 48 studies, most of the studies we were really looking at post-cessation outcomes like weight, HbA1c, and blood pressure, merely as a safety checkup at 4 weeks after they're on the drug, which really doesn't tell you anything. Um, what you need is long-term cessations, 1 year and beyond. All the studies that we sort of looked at, 1 year is sort of really the mark. They don't really go on to track cessation outcomes beyond 1 year. So we're really limited to that. But and also the other thing as well we're limited by is that this data is at a population level. So we don't really know because it's not given to us by these, but the studies are not reported. Um, Individual outcomes, we couldn't make much of a statistical analysis in terms of different individual outcomes. Sorry, different individual characteristics of patients. I would say that very clearly there is obviously we would expect that those patients that maintain a diet and exercise regimen that they're put on during the trial, that very likely could help maintain much of the weight loss. And that sort of makes sense because if you keep on these sort of healthier habits, you could potentially sustain them long term, and that's in keeping with other studies as well that have been done in terms of diet and other weight loss medications. Um, so that's potentially one of them. Whether dose tapering could work, that's a question that's open for still on the field, and I'm sure probably more studies will be done on that. But I think it's important to recognize that each patient is different. The data we're looking at is a population level, but patients are complex and you really need a holistic outlook to them. Um, and try to understand their sort of relationship with food and with exercise, and they really do need long-term support. I think it's very, very important to appreciate that that support has to be in place. It's not just as simple as giving them a drug and they lose weight forever. As brilliant as that would be the case, but that's not sustainable. also important to appreciate for these GLP-1 drugs is it's important that although you do lose weight, it's also important to think about what you're losing rather than not just how much you're losing. So actually, our study, this wasn't a finding in our study, but what we're seeing across the literature was that of the weight that you're losing, 40% of that weight loss is lean mass, which is muscle mass. So your weight loss isn't actually, entirely fat as people might think. It's actually 40% is muscle mass. And, it's not unusual to lose muscle when you lose weight. That's true with most other, actually nearly all other weight loss modalities, whether you're just on diet and exercise alone. But what we were really interested in, and this hasn't again been answered, is when you come off the drug and you regain the weight, what does the proportion of that regain look like? Are you regaining the same muscle and fat in the same ratio that you lost it? Or is the regain disproportionately fat? Of all the studies that we looked at, no studies reported the regain ratio, the fat to lean mass ratio, which is really, I'd say, a little bit concerning because, if individuals do regain disproportionately fat, then they could sort of really that could have quite adverse consequences for their metabolic health.